line pattern, you can give fluids, potentially, while you resuscitate the person as you're going along. This can also be helpful. So we're looking for the IBC. And remember our chart here. And remember, there's numbers you can come up with. You can measure it if you want to, but I wouldn't, because it's not clinically so relevant. So you think big and not moving, and you think small, okay, and collapsed, and there's a big area in the middle which is variations of normal. If there is some movement, remember it is a capacitance vessel, if there's some movements, you are safe at giving fluids, yes? If it's full and dilated and not moving, then you think, no, I think I'll hold the fluids for the moment, potentially for that. It's giving you information. It's not superseding all the information you're gathering, but it's helping you form, a judgment about what to do and what not. So this is roughly a middling IBC, yes. So one that could be normal. They could have a nice drink of a cup of tea, they'd be fine, wouldn't they? Want to come through it overloaded. What about that one?
Collapse.
Collapsed, eh? So you've got a collapsing IBC. Okay? So they've got a collapsing IBC. If you see B lines, the collapsing IBC, you could actually have B lines and pulmonary edema. They still could have that. And you might decide then to move on to a cardiac ultrasound. If they've got a collapsing IBC and no B profile or no B lines in the lung, you'll be thinking about, okay, they've not got pulmonary edema. Then I think about the reasons why they've got that collapsed IBC. The pipes are empty, yes? So you're thinking about hypovolemic causes of shock, distributed causes of shock. And this is a group where you might be giving fluids, yes? And when you've got this form of shock, then going immediately on to doing a cardiac ultrasound actually doesn't help you so much. Then you might move that extra step. You might decide, okay, this is someone who's got a hypovolemic shock. Have they got some blood loss somewhere? Does that fit your scenario? And then you might move them on to your fasting zone. What sort of IBC is that one? Distended one. So you've got a distended IBC. Okay? So you've already gone through the lungs. Do they have B lines? Yes. They have a descended IBC, which might tell you that they've got essentially a poorly heart. They've got big profiles, some fitting pulmonary edema. You then decide, okay, I think they've got a poorly heart. I will carry on with going on to look at my cardiac ultrasound. And for you, that might not just be the subcostal area, you might actually go to the apex as well. If you've got a distended IBC and there's no B profile in the lung, you haven't seen that global pattern of V lines, you're then thinking of what form of a shock? Obstructive causes. So what are your three causes? There's two written there. What's the third one? Pneumothorax. Have you decided that already? You've gone there first. You've ticked it. You've already looked at their lung. So if you're going down through this, you found there's no pneumothorax, you've ticked that one off. You've gone through, if you found that they haven't got any fluid on their bones, they've got descended IBC, you'll be thinking about the other forms of obstructive shock. That person is in shock. You'll be thinking of your pericardial tamponade and your pulmonary embolus. All of those lead to a cardiac ultrasound. And remember, be thinking about that subcostal view. So all that you learned yesterday, this is a tool that you'll add to what you learned yesterday. You do all of yesterday, and this extra thing that can be helpful for you. But you always remember as well the limitations of ultrasound. You might not get to the diagnosis, but you can certainly decide as to whether this is caused by hypovolemia caused by fluid loss because of blood fluid loss in the case of trauma, sepsis, and you've got the distributed forms of shock and sepsis, sorry. Your cardiogenic form can actually, you can have a big IBC or a small IBC. And we talk about the obstructive forms of shock. Many people, as they're older, of course, they can have a mixed picture. I'm not saying that this is a completely diagnostic for you. It is a helpful tool. So we're running through this. We've gone, are they shocked, short of breath and sick? Yes. I'm looking at their lungs. No beat profile. Can I give them fluids? Yes, I can give them fluids. No beat profile. Can I see a cause of their shock? Have they got a pneumothorax? Okay. I'm going through the finishing off their lung, looking at their IBC. Is their IBC distended or collapsing? Once you've passed it, you may come across a diagnosis as you go, but the next one you have a look at is the heart. So remember, when we look at the heart, here I'm using the phased array. Now, most of the machines here, and often I understand if you have an ultrasound machine, most of you will just have the abdominal probe, and that's fine. You use the abdominal probe and you look at the heart with the abdominal probe, and you look at the IBC with the abdominal probe. I've just shown you a picture with the phased array, the cardiac one, and for the cardiac one, remember that the marker goes towards the left-hand side of the patient. Remember the images that we saw, we come through the liver, and remember it's not just a right and a left side to the heart, there's a front and a back. It's the right that you see first of all. And the eyeball. So here we are, subcostal view of the heart. What do you think of that heart?
Hypodynamic.
Tachycardic. It's working hard. It's actually squeezing quite hard, it's working hard. And this is the case of the sepsis that we had in the previous lecture.
Cardiac temperament.
We can see a lot of that right atrium. I'm most interested with that pericardial effusion. I want to know whether it's tamponade physiology. It does look a bit stuttery because it's the way that the cine is formed and I'm looping it, so it looks a bit weird. But you see that right atrium, but it's not moving in, yes? The pressure on the outside of the right atrium is not overcoming the right atrial pressure during ventricular diastole. And this is more pericardial effusion, and we spoke about the possible causes. This is a complicated cause because of the fibrins thrombus. And with this one, I mean, the one that I would be concerned about, but I don't think it showed expressive tamponade physiology either. You see that seesawing, you see?
Yes.
Or remember my man bouncing on a trampoline? So you can already see the right atrial pressure is lower than the right ventricular pressure, and that's been overwhelmed, so that's actually been sucked in or coming in during diastole, but also so is the ventricle, so it's overwhelming the right ventricle as well. It gives that classic seesaw impact. And this is one that someone who has the experience and the knowledge would need to do a pericardiocentesis. This is a case of a trauma. And this is another one here. And remember, it's not necessarily the volume of fluids there, it's the rapidity that it's appeared. So in trauma, you get the fluid appearing quickly, but someone who's had slowly accumulating fluid over a period of many months, such as your TB cases or your malignancy cases, they can have huge amounts of fluid before it may have an impact and affect the physiology of the heart. And there's our other case. Remember we spoke about, it can be, you might find something like this, where we actually decide there's actually no cardiac output whatsoever. And it may form the basis of you making a decision about whether, you've done your cardiopulmonary resuscitation and you've been through all your cycles and, you've not got ROSC, and you decide, actually, let's have a look at the heart with the ultrasound, and there's no ventricular activity. So, this is further resuscitation would be futile if you might decide on this, okay? I also talked about the apical view of the heart, remember? So this is a little bit of an extended view. This is different from what is taught on the FAST exam, the extended FAST exams. But I think it's useful if you're going to learn some cardiac views. But this is so much better with a cardiac probe. And remember the images that I showed you and how the heart is upside down and what you're looking for. But the indicator you'll notice is on that right-hand side, which will denote the left-hand side of the patient. And you'll be looking at those chambers. So you're looking, remember, at the two chambers, that the right side should be 2/3 the size of the left. The atria should be relatively small compared with the ventricles. You must make sure that you get that image that looks like an artillery shell or a bullet. And if you put the probe, as you notice, if you put it not at the apex, but you put it too high, then you cut across it and it turns more like a box with a cross in the middle, with equal chamber sizes. So it needs to be a nice bullet shape. And you get an idea of the contraction. So you can see there that the muscle wall is contracting. Doesn't show up so well here, it's better on here. And also you see the ventricles moving in. So you get some idea by eyeballing LV function. So it's normal, mildly changed, moderately changed, or severe. And this one is? Yeah, this is
dilated cardiomyopathy.
Dilated cardiomyopathy. This is very severe. So this is someone, you can barely understand how they can push blood forward. It's only one cycle, unfortunately. The echocardiographer gave me this one, but they only do one cycle for some reason. A hugely dilated atria. And if you look at that, you recognize that as being unusual. Yes? Not a normal looking heart. And remember the heart we showed before? You see, you've got good movement and good contraction here, but it's not the same here. So that's someone who's had a myocardial infarction, yes? Throughout the whole of their apex. It's what we would call a regional wall abnormality. So can you see that? The difference there? It's moving a little bit in here, but look at this, it's not big, not moving. Okay. What do you think about this one? Tell me about the chamber sizes. Tell me about the right and the left. Huh?
Enlargement.
The chamber size, so the cavity size, is bigger than the left-hand side, yes?
Yeah.
Okay. So where it should be 2/3 the size, so it's become the dominant. So it's overstretched. And it's overstretched because it's been pushing against pulmonary hypertension, because there's a clot in the way and it's trying to work against the clot, but it's not that it's not strong enough, so it dilates open and becomes bigger. So again, with your obstructive forms of shock, you may determine this is a pulmonary embolus.
With a massive pulmonary embolism, it becomes dilated so quickly?
Yes. It becomes quickly dilated and it gets better quickly. So when it's interesting because when doctors started to do POCUS, we used to talk to the echocardiographers. We said, hey, look, we're getting all these PEs with hemodynamic changes. They're all getting dilated right hearts. And they said, oh, no, we're not seeing that many. And what would happen is someone would have a pulmonary embolus. They'd be treated, get better. They'd be referred to the echocardiographers. A week later, And by then it's all normalized, gone back to normal. So the more you look for this, the more you will find it. It's unbelievable. And this may determine, as say, someone who is shocked, it may help you determine as to whether someone may need to have thrombolysis, or someone who isn't shocked but has got this appearance to determine as to, if you see these changes, these are ones you've got to be very careful and look after in the hospital. So as we go through the protocol, so we're thinking, so remember, are they shocked, short of breath and sick? We've gone to the lung, pneumothorax or not. We've gone to the other two places to see have they got B-lines. My friend, the diaphragm, see around that area there where there's a lot of things you can pick up, see if they've got any hemothorax. Okay. And if they're of a B-line pattern, no, I'm not going to give them fluids at the moment, they've got a B-line pattern. Is the IVC distended or collapsing? And that can determine, okay, if it's big and distended, have they got an obstructive form of shock? I've already ruled out my pneumothorax, so you're then thinking of your pericardial tamponade, and you're thinking about your pulmonary. And if it's collapsing, okay, if it's collapsed, you're then thinking this is someone who's hypertensive, it's collapsed. Is this a septic case, is someone who's got a high fever, or is this someone who's been involved with an accident or trauma, having loss of blood from someone? So the extended images, and so you'll notice that it's taken us a long while, but eventually we've got to our standard fast. But it's reasonably quick to get there. And so if you've got someone who's had a trauma, you just remember your protocol go through here. And if you determine they've got a collapsed IVC, and there's someone who's got shock, you'll be resuscitating them, and then you can then think, right, they've been in trauma, I'll look for abdominal free fluid. And remember before as to what our limitations are. We're only looking for free fluid, we're not looking for organ injury. It's no good for looking for diaphragmatic hernias, it's no good for looking for which you've got a splenic laceration or a liver laceration. You may see it, but that's not the point. There is other form of imaging to determine that. You need to determine as to whether they've got free fluid and determine what to do with that patient. Are they immediately needing to go to theatre, or do they need to be transferred if you're in a rural area? And so it's informing you about what to do. And how much fluid do we need to see?
500.
Yeah, it's a lot, isn't it? It's not 15 mils, it's quite a lot to see. And it will depend on, the operator, But the more you do, then the more easily you pick it up. And what happens to blood after many hours? Yeah, that's right. It becomes hyper-echoic. It gathers echoes because it looks like more solid material. And then it becomes a little bit more hard to distinguish. Because blood flows in those areas, remember? And it forms those nice anechoic or black stripes, but after a while, it will become clotted and even look exactly like the organ next to it. So just be wary of that. And our right upper quadrant, remember on the right-hand side, mid-axillary line. And what do we do? That's right, the probe orientation. So we obviously have a marker going towards the head, as you all know. And so we'll be looking at Morrison's patch. Yeah, and we move up and we move down. So we move back up to my friend the diaphragm and make sure that we see that interface between the diaphragm and the organ below. And remember, we must move into the parapodic gutter, particularly on the right side, we must see that tip of the liver, mustn't we? And here are some pictures here. Morrison's pouch. Nice sharp angles, the way the fluid fits in. Fluid soaks in everywhere and fits in those angles. What's this?
Mirror.
My mirror image, that's right. And this is actually me turning it round to go transverse as well. So I've seen it in longitudinal, I'm turning transverse just to be sure of what I'm seeing. Because the more times you ultrasound, I'm showing you nice pictures, but in the real world, sometimes you need to have some certainty because there are many artifacts that can confuse you at times. A little bit of fluid or a lot of fluid?
Lot.
And that little tip, which you may have a clear Morrison's pouch, but unless you see that little tip, you might miss it. And on the left side, what's different about the left side? Kidney height, up and or posterior. So where do you have your hand?
More posterior.
Knuckles on the bed. And then you also go down into your parapodic gutter as well, yes? So you're moving up and you're moving down. And remember you're fanning posterior and anterior. At that dome with the diaphragm, don't be frightened of doing some oblique type movements. Because it's a dome, this is only 2D and we are 3D. So, you want to try and see as much of the diaphragm. And why do you want to see as much of the diaphragm, particularly on this side? Yeah, the first place it will collect is often between the spleen and that diaphragm, not in the splenorenal pouch. So it's a little bit different from the other side. Interesting. It's the more dependent area. Positive fast or negative fast?
Positive.
Yeah, so you can see that between the spleen and the diaphragm. Positive fast or negative fast? It's a difficult one, isn't it? It is positive. There is some here. But this is one where I'd spend, and I didn't mention this in my talk actually, but remember the word fast? What does fast mean? Do your ultrasounding fast as possible. No, so just remember, a falsely positive result is no good for anybody. Okay, you'll introduce treatments and cause all sorts of problems. You need to be a judicious, accurate fast, not a rapid fast that's wrong. Okay. So here I interrogate that more. I would, try and see more of the diaphragm. I would turn my probe a little bit until I'm sure that that is a true anechoic scribe. Positive or negative? Positive?
Positive. Yes.
This is actually the wrong markup. This is the here. So this is our liver tip, yes? So Morrison's is clear, blood in the liver tip. Positive or negative?
Positive.
So this is a slightly older machine. This is our kidney.
Liver.
And here's our stripe here. This is the spleen. There's a bit of a stripe there. So you won't always get perfect images. If I were to do this again, I would reduce the depth as well, and I would rotate around to be sure. And my eye says, well, that spleen looks a bit odd. And so this actually is an organ injury. But remember, it's unreliable. But you may see, if you see something you recognize, no, this is pathological, you might see some other weird things, in which case you flag that. Perhaps get someone else to scan. So this is now on the splenic side. What are we seeing here? Oops. I'm scanning posteriorly and then I'm going anteriorly. So what might I see? It's a bit weird. It's the stomach. So just remember, as you fan anteriorly around the spleen, you see something weird and you might get confused if there's something odd going on. And that amorphous appearance there is, food and fluid in their stomach. So don't get confused by that. And now we're down in the pelvis. Yes. How far are we going to go down to have a look at the bladder? Yeah. Hit the symphysis pubis so that you have your bone and your posterior pubic gathering, and then your next organ is your bladder. Yes? Okay. And then transverse view, we're looking with the probe marker towards the right hand side, and it looks a bit more like a box there. And remember, you want to fan through the whole of it. So once you've done all your pubis, you want to make sure you fan across. My sonographer tells me borders, boundaries, and beyond. You want to make sure you see either side, up and down. So you sweep through the whole of the bladder. Okay. And what happens here? What's the difference? So this is us telling the machine, we're told this machine automatically to enhance this area because, you know, it's one of the falsehoods about ultrasound. The ultrasound assumes it's all one speed going through tissue, but the tissues vary. As it passes through water, it goes through really fast, and so the machine has erroneously enhanced this area. So you need to turn down the far gain in order to see the back here. So that's a particular important thing for the bladder. When I was in the ED and I was looking at all the ultrasound pictures coming back for the patients, nearly every one of them showed the posterior acoustic enhancement. The gain needed to be turned down. And that's the far gain. So, other causes of bleeding, a very common problem that you may see is a woman who comes in with pelvic pain and bleeding with a positive pregnancy test. Okay? And here we find some free fluid. So this is our longitudinal view. So this is our bladder.
Bladder.
This is our
Uterus.
and this is yeah. Okay? And this is our transverse view. This is our uterus. This is our free fluid. Now, if this were the only amount of free fluid that you had, with no free fluid elsewhere,
Normal.
it could potentially be normal. So you just need to be aware. It may be because of, an ectopic pregnancy and bleeding, but 5% will have amount of it. I think it's more than that actually, because I see it quite a lot. So just be, if that's the only place, just remember that can be normal. But you would then perhaps go on to do the other, complete the course of the fast scan. So we've got fluid here, the Morrison's pouch, and we've got, that's the transverse view, and then we've got it again, where's it collecting between the spleen and the diaphragm. How many bladders have we got? You went to my talk at the conference. But let's just say there's one bladder only normally. Okay. So this is the synthesis pubis, yes, the bone, and we get the process of shadowing. So the organ next to it, the cystic organ is the bladder, and the bigger area that we might be confused might be the bladder is actually the free fluid. And this is our transverse view. So sometimes, if you're expecting to find a bladder, you might just concentrate on this and, yeah, there's the bladder. The small thing in the corner is the bladder. And here is the bowel floating around. And there's another picture. The bladder could be tiny, the smaller, and this is the free fluid. This is from my organisation. This can be completely different. It all depends on where you are and your processes, which hospital, how big it is, whether you're in a trauma centre, whether you're in a university hospital or community hospital, or even a small hospital, or even a district somewhere. So it will change. So just remember that there is a difference between your unstable patient and your stable patient, and whether you get a positive fast, and what that means. In some places, even going via the CT scan could be the death of the patient. So they might have algorithms where they have an unstable patient, they've got a totally positive fast, and they go straight to the operating in order to expedite things to save their life. Okay? So it all depends on where you work and how you deal with it. But this is the group here. You've just got to be judicious as well about the people you do fasts for. If it fits the clinical scenario, you do a fast. Or if you're learning and the patient's happy, you might be doing more fast scans. But it's very good. You may have no signs, not enough free fluid initially. You're a bit worried about the case. When you go back and you revisit and you do a second fast, you might find the free fluid as it collects more. So it really depends on the scenario as to what you do. And this is just a little bit more, this is just to whet your appetite for the utility a bit more of ultrasound. So this is more of a common problem where I come from. So I live in a community that we have lots of retired people. And this is someone who has got an abdominal aortic aneurysm, which is this. And they came to see me 1 year with abdominal pain, and they were in their 80s, and they also were a bit hypertensive. We resuscitated and transferred them to Lillian because they wanted to have care, and they ended up with a repair of this, an endovascular repair of their abdominal aortic aneurysm. And then they had 4 more years of quality of life, and then they came back to see me again. And they had the pain, same pain scenario, unwell, and also they were hypertensive again. And this has failed. And actually, this is what we call color Doppler. And it's meant to be flowing in the middle here through here, but it's actually flowing around the aneurysm here. So this has failed. But just to show you that one of the reasons in the retroperitoneum, while someone might be shocked, you don't see any free fluid or anything like that. So this is a reason. This is one of the reasons, or one of the things that we have in our country. If I'm concerned that someone might have a pulmonary embolus, I might go on to do have a look at their legs for a DVT, and it's not shown very clearly, I don't think, but this is their femoral vein. This is their greater or their long saphenous coming in, and that's often up that junction. And this here, this tongue here, is clogged. So it was helpful for me to determine that their cause of their shortness of breath was actually a pulmonary embolus, and I was able to have a look at the legs as well. You might have somebody who comes in with sepsis, and you might be looking for the causes of sepsis, and in that suite of extended things you might be able to look at as your skill set increases. This is someone's gallbladder. This is the dilated bile duct. And this is something casting a shadow here. What's this?
Stone.
Yeah. So this is a biliary stone. So they have obstructive jaundice, okay, from this, and they were septic with that. This is actually someone who came in just a little bit like the scenarios before. This is someone who has come in with a positive pregnancy test, who's come in hypotensive. This is the uterus. And as I look at the uterus, I mean, what is this? As I look at that, that is a pregnancy that is in this, the salpinx, okay, in the tube. So it's a tubal pregnancy, and so they have ectopic pregnancy. Pregnancy in the wrong place, and of course they're important. This is someone's liver. This is actually from the Gambia. This is someone who came in with this. No, they didn't have high diabetes, but it could be. That's in the differential. Media gaps. So that's just a little bit of a taster at the end. There are lots of things that you can learn as you pick up the ultrasound, and you learn more and more. And you can learn ultrasound in a modular fashion. But just going through what we call this slice technique, just means to start off doing things in an algorithmic way that you can just switch to, so that you don't become overwhelmed. Oh, what do I do in what order? What do I do next? You can just go through your learn through. And this is just one strategy to use. And I quite like it. Any questions?